Hello and welcome everyone. So today let's learn about normal labor. And the chapter is all about the physiological process of childbirth and its mechanism. So let's quickly start. Okay, so now let's start with what is labor. Okay, so it is a series of event in the genital organ to expel viable product of conception. So now what are those? Those are fetus, placenta and membrane. Okay, so from the womb through the vagina, so it is the event in the vaginal organ to expel the viable product of conception. Okay, and this is characterized by regular uterine contraction, one, there is a cervical effacement and dilatation. Okay, and then there is a fetal descent. Okay, so now let's also learn about the certain uh, um, terminology. What is parturient? It is the patient in labor. That means the mother who is in labor is called parturient. Okay, and the parturition is the process of giving birth. Okay, and delivery is, it is expulsion or extraction of viable fetus. Okay, so there is also one thing that and one thing that you also have to remember: the labor can occur before 37 weeks of gestation, which is also called as preterm labor, or involve a pre-viable fetus, mini labor. Okay, or delivery can be vaginal, which can be spontaneous or aided. Aided means either use of a forceps or vacuum. Okay, or it can, or the delivery can happen through abdomen, which is also called as cesarean section. Okay, and certain cesarean section are also called elective cesarean section, which is done without labor. Okay, before the labor start, the delivery is done or is taken place. Okay, so now let's quickly learn about what is normal and abnormal labor. So the normal labor is also called as eutosia and abnormal labor is called as dystocia. So in eutosia, what are the criteria of the eutosia? So the first is spontaneous onset at term, which means once the mother is at term, or with that means 37 or beyond weeks of gestation, the labor should start spontaneously. Okay, number two, it is the vertex presentation is the normal one. So okay, the vertex presentation is the normal. And number three is the without undue prolongation. So the labor, once the labor have started, and the delivery should not cross beyond 24 hours, which means, which is also where we expect the mother, primary mother, to deliver the baby by or within 12 hours, and for multigravida it is expected within 6 to 8 hours. Okay, and number 3 4 is natural termination with the minimal aid, which means it should the delivery should happen through normal vaginal delivery. Okay, so, and it should be with minimal aid, which is only with a perineal support. Number 4, it is, sorry, 5, it is there is and this labor should have no complication affecting both the mother and the baby's health. Okay, now coming to dystocia. So it is or any deviation from the normal labor. So the criteria are non-vertex presentation, so that might be buttocks presentation, that might be face presentation, okay, shoulder presentation, any. Okay, so the it is non-vertex presentation, that is called dystocia. Number 2, complication affecting the labor courses, any complication related to mother or the fetus. If it is affecting the course of the labor, then it is also called as dystocia. Number 3 is the modified termination nature, so that is by through cesarean section. Okay, and number 4 is adverse maternal or and fetal prognosis. uh, if the labor causes any adverse effect to the mother or the fetus, so then that is also called as dystocia. Okay, so now let's see the stages of labor. We have 4 stages of labor. First stage, also known as cervical stage, where it starts from the true onset of the labor pain to full dilatation of the cervix, which is 10 centimeter, and the total time it takes is 12 hours for primigravida and 6 hours for multipara. Okay, now in second stage it is also called as expulsive phase, and it starts from the full dilatation of the cervix to the expulsion of the fetus. Okay, here we have two phases. First is the propulsive phase, where there is a descent of the fetal presenting part to the pelvic floor, and then there is an expulsive, which is the maternal bearing down. Okay, and this duration takes place takes place uh, 2 hours for the primary gravida and 30 minutes for the multipara. So we and then after that we have third stage, which is also called as placental stage, where there is the fetal expulsion to the placental delivery. Okay, and membrane delivery also. The duration maximum is 15 minutes, and but if you do active management of third stage of labor well, so it can be reduced to 5 minutes, but this should not exceed more than third stage should not exceed more than 15 minutes. Okay, fourth stage, it is also called an observation stage, where you do 2 hours of monitoring of the mother in the labor room only. Okay, so first hour, 15 minutes, you will be doing the assessment or observing the mother, and after that it will be half of hour, and after that, after 2 hours in the labor room, then you will be shifting the mother to the postnatal ward. Okay, so now let's learn about the onset of labor timing. Okay, so the exact date of the labor onset is unpredictable. First thing that you need to know, and it varies between the cases and even different pregnancy of the same individual. Okay, so that is why the Nigel's formula provides only rough calculation or guidance. Okay, so the chances of a labor to start on that expected date is just 4%. Okay, and the chances the labor starts within 1 week is 50%, and the probability of the labor to start within 2 to 3 weeks is 80%, and at 42 weeks it is just 10%. Okay, okay, so now let's see the causes of onset of labor. So the first, the precise mechanism remains obscure. The causes of the labor remains obscure. It is not very clear, but there are several pathways that contributes to labor initiation through endocrine, biochemical, and mechanical stretch mechanism. Okay, so the first one is because of the uterine distension. Okay, due to the growing fetus, it stretches the wall of the uterine, it stretches the uterine wall. Okay, so now what does it do? It eventually increases the gap junction protein. Okay, now what does this gap junction protein do? It helps the smooth muscle cell of the uterus connect more closely, so that the whole uterus contracts together as one. Okay, so there is also an increase in the oxytocin receptor. Okay, so what does this receptor do? It helps the this oxytocin receptor makes the uterus more sensitive to oxytocin, and this and and after that there is also an increase in the contraction associated proteins. So now what this also does is it helps the uterine muscle contracts effectively. Okay, so number two, there is an hormonal changes. Okay, so there is an alteration in estrogen and progesterone ratio. Okay, so from progesterone dominance to estrogen, the changes happens from progesterone dominance to estrogen dominance. So now what this alteration does is there is a synthesis of prostaglandin. So now what does this prostaglandin do? It softens the cervix. Okay, there is a cervix ripening. Okay, and it also stimulates the uterine contraction. So and then there is also a myometrial sensitivity. So what does this do? It increases the uterine muscle. Okay, sorry, the it becomes more responsive to oxytocin and prostaglandin because of myometrial sensitivity. Okay. So now we also have a fetoplacental contribution. So what happens as the fetus mature, um, um, its hypothalamic pituitary adrenaline axis activates. Okay. So now what does this activation do? It increases the it releases CRH, which is the corticotropin stimulating hormone. Okay. Now what does this do is it further stimulates the pituitary gland of the fetus. Okay, which then secretes the ACTH. Okay, which is adrenocorticotropin hormone. Okay. And now further what this hormone does is it stimulates the fetal adrenaline gland. Okay. Now this adrenaline gland produces corticosteroids. Okay. Now this corticosteroid is actually the reason or cause of altering the estrogen and progesterone hormone. Okay. Now due to the alteration in the progesterone and estrogen, there is a production of prostaglandin. Okay, prostaglandin. So hence there is a cervical ripening, there is a uterine contraction. Okay. So these are the causes of the uterine of labor. Okay. The first is the uterine distension. After that there is a hormonal changes, and there is also a fetoplacental contribution. Okay, now let's see what are the signs of labor onset. Okay, the first is the lightening. So it is the after 36 weeks of gestation, there is the presenting part shrinks into the true pelvis. Okay, and in primary gravida, this happens 2 to 3 weeks before labor. Okay. Number two, there is a cervical ripening, which is the cervix becomes soft. Okay, because so becomes soft, and there is an 80% effacement. Okay, hence it admits one finger easily. Okay. Number two is you'll also see true labor pain there, which means there is a regular progressive contractions with increase in the frequency, intensity and duration. Okay, so because of that there is an changes in the cervix, and fetus also descends. So after that, number four, you'll also see show, which is a cervical mucosal plug, which is mixed with a tint of blood also. Number five, you'll also feel a bag of water. Okay, so when you do a PV, you'll also see lower fetal membrane bulging into the cervical canal. Okay, and it becomes tense during contraction. So these are the signs of labor onset. Lightening happens, cervical ripening happens, true labor pain is there, show, and bag of water. Thank you so much. If you like it, please do share with your friends. Do not forget to like and subscribe.